Thank you very much. I'm very happy to be here. I apologize for not speaking Spanish. I even apologize because my English is not so good. I come to you in Chile understanding that they're the soccer champions of South America, but from Cleveland, where I'm from, we're the basketball champions. So we have a huge common interest, except for the people from Spain and Argentina and other places who are not so happy. So there will be no facial reconstructions. There will be no fat transfers. What I'm going to try to do is talk about MSCs and talk about the history of them. So these are my disclosures. I started a company called Osiris Therapeutics. I have nothing to do with the company. I steal some of their data to make my scientific points. The university gets some royalties, which they split with me, which won't pay for coffee for anybody. I'm a consultant for lipogens. You'll see why that's important. So I'm going to talk about the past. So 1987, I came to Santiago and then to Viña. So this is what I left in the United States, a beautiful beach, summertime in September, and came to Santiago and froze my body off because I didn't bring a winter coat. This on the bottom is the way I looked then. And this is my family now. So you can see my little daughter, teenager, married and has 3 wonderful children. So this is then, and this is now. So this is the hotel that my sponsors put me in 1987. It was a horrible, small hotel just off the city center. And this was what the university looked like in Santiago, because Pinochet, for the young people, Pinochet was still in power. And so all these university crazy people were making demonstrations, quite reasonably. And what you don't see here are the police with automatic rifles. Scared me to pieces. I thought I was a tough guy until I saw these demonstrations and immediately got on the bus to get out of town. So this is Viña. You can see this is all there was. There were no tall buildings, no Sheraton Hotel, no any buildings on the hills on this side. Valparaiso, yes. Viña, 1 or 2 small houses. This house is still the same, but the rest hugely different. This is my friend Jose Arias. Of course, he took me in this van, and of course, in Viña, he had a flat tire. And so my crazy Chilean friend changed the tire while other cars were trying to hit him. This is his family, and you can see his beautiful wife is still the same. She's here at this meeting. And this is Ignacio Arias. I don't know if he's in the audience, but he's as cute now as he was in 1987. And this is actually Pepe Manuel, who actually was one of the people who started me to think about MSCs. So Chile plays a huge role. 1987 is when I just started working on MSCs. So that's then. So this is a page from my histology textbook, Bloom and Fawcett, in 1963. And little old men in the hematology service from blood smears deduced the entire hemopoietic pathway, not from any fancy molecules, not from any cDNAs, but what they showed was that from these cells, which they identified as the hemopoietic stem cell, there were these series of differentiation steps until you finally got an erythrocyte. The entire lineage pathway deduced on blood smears on just morphology. We now know the names of all of the molecules that control these differentiation steps. And we know, for example, that the molecules that are involved here also control this step. So it's a very complicated three-dimensional pathway that occurs in your bone marrow. And so this is the way my engineering brain imagined the stroma of marrow, this scaffolding on which the hemopoietic stem cell differentiated to neutrophils or erythrocytes, etc. And the star is the marrow stromal cell. So if you make a lawn of marrow stromal cells and you put hemopoietic progenitors on, you get the whole pathway on a petri dish. So these stromal cells not only make the three-dimensional scaffold of marrow, but they made molecules that controlled individual steps in the lineage. And this is how I pictured this. But of course, there must be a progenitor for the stromal cell, right? So what I assumed was that the marrow was composed of the hemopoietic stem cell and all of the blood cells that derive from this cell. And I assumed there was a progenitor for stroma. And I called this cell a mesenchymal stem cell. Mesenchyme being the middle layer of an embryo that makes cartilage and bone and tendon and connective tissue. And I drew this diagram. So this is a hypothesis, totally a hypothesis slide. We knew a lot of the details of the osteogenic lineage at that time, and we had data with regard to these different steps, but I proposed that this cell could go to bone or cartilage or tendon or bone marrow stroma or tendon ligament or fat or dermis. And I can tell you that what we've published since the late 1980s proves that in tissue culture, we can do all these pathways. And if you want to do tissue engineering, you have to understand this lineage pathway and how to manipulate it. So my nose cartilage, ear cartilage, throat cartilage, sternal cartilage, hip cartilage, knee cartilage, ankle cartilage, all completely different. If you take ear cartilage and you put it in your knee, it'll rip your knee to pieces because the ear cartilage, which allows me to fold it like that, has huge rods of elastin, rigid rods. You put weight on that, it'll rip your knee to pieces. So the management of the lineage pathway to get the right cartilage for the right place in the right time, whether it's your ear or your knee or your hip, makes a huge difference. So those, I can say no one, unfortunately myself included, is able to do that. Diego Correa is working on it. Guys in my lab are working on it. We think we have the logic, but we're not there yet. So for regenerative medicine, it turns out the key is in the top, in the MSC itself. So what I'm going to do is tell you the end of the story. I'll talk more about it at 5:30. I'll give you the maxi lecture. This is the mini lecture. So the Caplan dogma is that all MSCs come from perivascular cells, pericytes. So these cells sit on every single blood vessel of your body. When Diego Correa took his blood pressure medication this morning, This is the cell that responds. You want high blood pressure, it squeezes the blood vessel. You want low blood pressure, it relaxes. This is the contractile element of every single blood vessel in your body. So what I'm going to show you now, every cell you see is a pericyte. I'm not going to tell you what tissues this is in. Every cell you see is a pericyte. Every cell you see on the outside of the vessel is a pericyte. Every cell you see on the outside of the vessel, every blood vessel of your body, without exception, has mesenchymal cells on the outside. When you look at the list of every tissue of your body, I can isolate MSCs from every single one of those tissues. I can make those cells dance on a petri dish, make them go into bone or cartilage or muscle, regardless of where the MSC comes from. What's missing from this diagram is that the MSCs come from the blood vessel. That changes the way you think about these cells, because in vivo, they don't dance the way I make them dance on a petri dish. They don't differentiate in this way. So when the blood vessel breaks, the pericyte comes off and becomes differentiated into an MSC. So you have to look at, everybody has to look at me, forget about the slide. This is a blood vessel. Pericyte on the blood vessel breaks or becomes inflamed, the MSC is differentiated from the pericyte, and from the front, it makes a curtain of molecules locally that stop your overaggressive immune system from interrogating the damaged tissue behind. This is your first line of defense against autoimmune reactions from starting. From the back of the MSC, it makes molecules which help that injured tissue to regenerate. Every tissue of your body, every single tissue of your body has its own stem cell. You have a heart stem cell, you have a neural stem cell, you have a liver stem cell, you have a kidney stem cell. Every tissue, skin, easy to think about. You have keratinocyte stem cells, you have dermal stem cells. You have fat stem cells. You have liver stem cells. So every tissue, without exception, has a stem cell. The MSC manages the tissue to regenerate itself. It's a manager of reactions at that site. The MSC does not become heart, does not become nerve, does not become liver. The MSC makes drugs for sites of injury. So, of course, I have an enormously delicate ego, and I need you to keep calling them MSCs, just so I won't become depressive. Okay, but everything I just said has nothing whatsoever to do with stem anything. So the drugstore is, the way I renamed the cell is to call it a medicinal signaling cell. It's not, I'm begging you, it's not a stem cell. So if you're giving patients medicinal therapy, you're not giving them a stem cell treatment. Rethink this idea. So MSCs, when you put them in externally, go to sites of injury, immunoregulate the site, and help the site regenerate. So the MSCs manage the innate regenerative capabilities of that tissue. So if you have a heart attack, it protects the heart against damage for cardiomyocytes that die. The cardiomyocyte stem cell divides and makes new cardiac myocytes. The MSC does not become a cardiac myocyte. So if you go to this website, clinicaltrials.gov, and you put mesenchymal stem cells in their search engine, right now 644 clinical trials now listed in that website. This is a map of the United States. This is not a political map. Usually red means Republican. In this case, red means the states that are doing the most clinical trials, so they're my favorite states. This is South America. So my good friends from Argentina are way ahead of the people from Chile in terms of the listed clinical trials on this website. Pardon? Brazil, sorry. That's a small difference. They're right next door to one another, and they share the same falls. That shows how ignorant we North Americans are of geography. So these are all the clinical symptoms on the website. So this is not an eye test for all the people in the back, but I put it in bigger font. Crohn's disease, MS, ALS, kidney transplant. There's a fabulous paper whose first author is Tan, T-A-N, in JAMA 2010, 159 kidneys transplanted in China. 1/3 of the patients hugely IL-2 immunosuppressed. 1/3 of the patients lightly suppressed, so these patients are going to have problems. And 1/3 lightly suppressed and given bone marrow MSCs that have been culture expanded. And the genius of this protocol is when you do the microsurgery to hook up the new kidney, you then release the tourniquet to perfuse the new organ. At that moment, they gave the first dose of MSCs, so that all those, we call them leakers, that leak a little bit of blood, they're perfect for the MSCs to go and help fix. 2 weeks later, for all the problems that still exist, another dose of autologous culture expanded marrow MSCs. The 1-year outcomes, no rejections, no infections, perfect kidney function, no problems. The people who are on severe IL-2 immunosuppression have problems. So I'm gonna just quickly tell you the complete mind blower that was totally unanticipated, which is the work I've done with Tracy Bonfield, my esteemed colleague who's across the street in Rainbow Babies and Children's Hospital. And this hospital is famous for treating patients with cystic fibrosis. So these patients have mutations in a transmembrane conductance regulator gene, and those mutations cause mucus and other problems for these poor kids, including huge lung infections. And what kills these young patients is Pseudomonas infections. And so what they did, they took a mouse and took this gene out of the mouse. So it's a cystic fibrosis knockout mouse. So in this case, if you give, we take an agarose bead, we put Pseudomonas in the agarose bead, and we physically put it in the lung. So in the wild type animal, you get a huge lung infection with Pseudomonas. 1 week later, they're completely cured, no problem. The wild type takes care of it. Cystic fibrosis knockout mouse, every animal dead at day 7, every animal. If on day 2, we take some marrow from Diego and we get his MSCs, human MSCs, culture expanded, we put it into this mouse, the mouse walks away. So Diego's curtain works in mouse. And we have several other models that we always use human MSCs, purified culture expanded MSCs in mouse models. No problem, the curtain works. The cells are not privileged, they're hiding behind the curtain. so the immune system cannot see them. Not the immune system. MSCs make this molecule called LL37. It's a powerful protein antibiotic, kills bacteria on contact. So women who have huge monthly bleeds never get sepsis. I just told you the answer. Why? Blood vessels break in the uterus. MSCs come off the blood vessels. If they bump into a bacteria, the bacteria is dead. Not only that, but LL37 collects, brings in a macrophage to get the carcasses out of there, so there's no endotoxin effect. So all of you, every single one of you is dying for lunch. So in your mouth, you're making molecules called defensins, which LL37 is one of them. That's how you control the bacteria that go to the GI tract. So this is in the genome. MSC sees a bacteria, kills it, makes this molecule automatically. So MSCs are sites of, go to sites of damage. They immunoregulate, they help the tissue regenerate, and if there's an infection, they kill the bacteria. There are now actually clinical trials for sepsis using MSCs. So they manage the body's innate capacity to regenerate and fix tissue. So this is the original hypothesis. It's wrong. What's missing is the perisite is what gives rise to the MSC. And that changes your thinking. MSCs are not stromal cells. They're perivascular cells, and they naturally in your body have a process called being a sentinel for protecting and regenerating that tissue. So I want you to keep using MSC. It's important, but it has nothing whatsoever to do with stem cells. It has to do with medicinal signaling capabilities. This is Rodrigo Somoza from Chile, from Viña, who came to my lab, and with Diego Correa, we created this poster, which you can go to this website. It's a nature poster. You go to this website, you can download this poster. This is all the new and interesting information that has to do with MSCs. And it's completely different than that original hypothesis slide from 1988. And there's some really important messages here. One message that's absolutely central is hidden in the middle of the poster. And every stem cell, whether it's a liver stem cell or a cardiac stem cell or a hemopoietic stem cell, is sitting next to a perisite MSC, and both of those cells are in contact with endothelial cells of blood vessels. This is called the stem cell niche. And this is what is in every single one of those tissues, every tissue-specific stem cell sitting next to an MSC. So for the hematologist from Spain, this is for you, because of all the wine I drank last night next to you. Here's the MSC sitting next to an active hemopoietic stem cell, and here's an MSC sitting next to a quiet stem cell. They have different molecular signatures. We can sort them out of marrow. And it makes sense that the quiescent stem cell, the active stem cell, requires different support molecules. Not only that, but every doctor in the audience was taught in medical school that the vasculature is hooked up to the sympathetic nervous system. Wrong. Wrong. Hello, wrong. It's hooked up to the perisite MSC because that's the contractile cell associated with every blood vessel. This is the cell which contracts. Endothelial cells have no apparatus to contract. So the sympathetic nervous system is hooked up to the perivascular layer, not to the endothelial cells. Yes, to the blood vessel, but not to the cells that make up the blood vessel, the endothelial cells. So get this poster. Look, there's tremendous amount of information on this poster. All of it's current, and it changes the way you think about MSCs. Certainly, they're not stem cells. So my prediction is 10 years from now, somebody on the hills of Valparaiso gets a heart attack. Helicopter comes, picks them up now, takes them to the medical center. 10 years from now, they're going to walk 2 blocks to the urgent care center at the local clinic. From the freezer, they'll take a bag of Diego Correa's MSCs, put it into their blood system, and protect their heart from damage. That'll be the therapy of the day. Cell-based, allogeneic, off-the-shelf therapy for stroke, for heart attack, for MS, for ALS, for rheumatoid arthritis, for lupus, for osteoarthritis. The use of these cells will change the way we practice medicine. So this is my favorite quote. I use it at every lecture. I think for cell-based therapy, we're at the end of the beginning. And it's going to start a new way to practice medicine and to use these cells. So all the data from my lab supported by the National Institutes of Health, and of course there's a huge number of people at the Skeletal Research Center who provide the data. I'm clearly just the mouthpiece who stands in front of you, so they deserve all my gratitude. Thank you.